Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of a young woman who presented to ER with acute breathing difficulty.
Okay.
So there was this 42-year-old female who presented to our ER with complaints of acute onset of breathing difficulty. A little more into the history, this patient was undergoing a transbronchial lung biopsy procedure, following which she developed acute onset of severe breathing difficulty, which is why she was shifted to ED for further management.
So here the acute dyspnea of duration. Since how long?
Post procedure. So while doing the procedure, she was undergoing
maybe minutes
transbronchial.
or hours after the procedure.
1 hour.
About an hour later.
After that is more precise. No, see within seconds or within minutes is different. Within an hour is different. After 1 or 2 days, everything is post procedure means that is a vague terminology. Okay,
sir.
good.
An hour later, she developed acute onset of breathing difficulty, and so she was shifted to ER for further management. So in our initial 10-second assessment, patient was conscious, oriented, obeying commands, but she was little tachypneic with increased work of breathing. Moving on to the primary survey, airway was patent as there was no obvious secretions or anatomical deformities. Hoarseness of voice was not there, and she was able to talk in one full sentence. Breathing wise, patient had a respiratory rate of about 32-33 cycles per minute and was only maintaining saturation of 87% in room air. Patient was tachypneic with increased work of breathing, and air entry was reduced on the right side.
Okay. So you have an lady who had come with post procedure. 1 hour later, she developed breathlessness. So what procedure exactly she underwent?
She underwent transbronchial lung biopsy.
Transbronchial lung biopsy. Okay. And now her saturation is only 87% on room air. So what you have done immediately?
Put her on a face mask, and then we increased it to about 8 to 10 liter per minute.
Okay.
Oxygen was given, following which her saturation improved.
Okay.
But work of breathing was still
On the higher
on
side.
the higher side. She was little tachypneic to be.
Why that transbronchial ultrasound was planned?
So she had a
Biopsy?
background history of ILD
Okay.
with pemphigus vulgaris, and outside bronchoscopy was done, which was not really giving a typical picture of an ILD. The lower zones were spared, so they wanted to find out what those infiltrates and all of that were on the X-ray that they saw.
Okay.
X-ray had haziness and infiltrates were
So
there.
basically, a possibility of an ILD they were considering. For a confirmatory diagnosis, they went ahead with a lung biopsy.
Lung biopsy, so. Following which she developed tachypnea.
Okay.
So circulation wise, she was tachycardic with heart rate of 106 beats per minute, maintaining blood pressure of 110/80, warm extremities, and all peripheral pulses were palpable.
So why the most important thing is circulation? What is the important thing that you need to check?
Hypotension.
Okay,
Patient can go into hypotension.
So if it is hypotension, then
We'll have to think of tension pneumothorax. The whole patient becomes unstable, and then if it always suspect, because patient had decreased air entry on the right side,
Right
plus
side.
there's a strong suspicion for pneumothorax because patient was undergoing a lung procedure, biopsy procedure. So at this point in time, if
there is
it
a high likely chance she had a pneumothorax, and if there is associated with hypotension, we definitely need to consider tension pneumothorax. Okay.
So then ABCD disability wise, patient was fully conscious, oriented, and pupils were also reactive. GRBS was normal in the exposure part, but she was afebrile, but we still covered her to prevent hypothermia. And in the primary adjuncts, we took an ABG. So ABG showed pH of 7.39. PCO2 was 55.2, and at this point in time we had already started her on oxygen. PO2 was 275 and bicarbonate was 33.3.
Why the PCO2 is on the higher side? You said the patient is tachypneic, and we are not expecting a PCO2 to be 50s. Why that is a PCO2 built up?
Well, she has some chronic history in the past, maybe.
Okay. Chronic history in the past, ILD. See, the one thing that we can come to know here, pH is maintained right now, 7.39. So 7.39 pH and 53 PCO2, as you said, it can be a chronic respiratory acidosis. But what is the bicarbonate here?
33.3.
So that again focuses more towards a chronic issue. So suppose it's 55, what will be the expected bicarbonate? You can take it as a chronic respiratory acidosis. So there is a 10 increase. So 10 increase, you can have an 4 increase of your bicarbonate. So bicarbonate 33. So it is still on the higher side. So why there is an increase in bicarbonate?
That is
There is some amount of alkalosis also. So there can be some amount of either a metabolic alkalosis or with the history, there is some metabolic alkalosis also. So there is a respiratory acidosis with a metabolic alkalosis. So when you see a metabolic alkalosis, what is the next question? What is the potassium?
Potassium levels. Potassium levels are normal, so 4.3.
4.3. Whether she has received any dose of Lasix, furosemide or not, whether because of post-procedure, they thought breathlessness, they can be a fluid overload, they might would have given. So these are the possibilities that you need to consider. So the PCO2 55 may be due to their chronic respiratory acidosis. Maybe her PCO2 would have been somewhere around 65. We don't know. Maybe because of the tachypnea, there is some washout also happening during this time. So that is why it is 55, but still it is on the pH is on the normal range. So that would be the reason. There will be a chronic disease. As you said, it can be an ILD or there is some disease that is causing carbon dioxide retention. That is a chronically happening, and on top of that, she has developed this breathlessness.
What is the pulse rate and BP of this patient?
Pulse rate was 106 beats per minute. Blood pressure was 110/80.
Any other adjuncts that you need to do?
ECG, sir. ECG showed sinus tachycardia. Apart from that, there was no other S1Q3 embolism.
See, 1 hour post procedure, we are not suspecting any embolism. So suppose this patient, there is no other risk factors for her. She is otherwise actively mobile or in anything. So we are not suspecting an embolism. So tachycardia, and you have to look for any other reason for her to develop this breathlessness. So she don't have any other features of STT changes. Then what other adjunct you want to do?
We can go with bedside ultrasound.
Okay.
Bedside ultrasound, when we placed the if in a normal patient, when we put a bedside ultrasound, we will be able to see lung sliding.
So which mode you will select for that?
First, we'll have to take a vascular probe, and then on the normal ultrasound, when we place, we'll see 2 rib shadows. Between 2 rib shadows, we'll see a bright hyperchoic line, which will be sliding over the other. So that is called as a lung sliding, and that's a normal finding. So after that, we'll have to trace vertically downwards through the lung feeds bilaterally to check for lung sliding. Now, if at all there is no lung sliding, that is suspected of pneumothorax. So following which we'll be putting M mode. So normally we are supposed to see a seashore appearance, wherein the sea will C meaning there will be vertical line, horizontal lines. Those will signify pleura, and then there will be grainy appearance down, and that will be the lung tissue, and it will that is the shore.
So differentiation you will be able to see.
We'll be able to see, but if at all it is an pneumothorax, all we'll be seeing is a barcode appearance, meaning the entire thing will only have a horizontal line. So in this patient, the right side, we could see. On M mode, we could see a barcode appearance, and lung sliding was absent on the right side.
And clinically also, there was no errantry on the right side, and the biopsy was done. So more in favors of it, the patient developed a pneumothorax post-procedure. So, and all.
What other complications do you expect when they are doing a
Bronchial
biopsy?
Hemorrhage can happen, sir. Any arterial vasculature can happen. So vasculature, then pneumothorax.
Blockage of lobar or segmental bronchi. So that itself also will produce hypoxia. A gas exchange will be diminished. There may be one entity of pneumothorax, or in addition, we have to
look into
other complications also. So hemorrhage usually it will be coming out through the two upper respiratory passages also, or it may get blocked. So once it clots the passage itself. So.
Okay, so she has a pneumothorax. So what will be the action plan? We really need a chest X-ray. Yes, you can take a chest X-ray. We have time, so you can take a chest X-ray and confirm the diagnosis. So, so what will be your action plan here at this moment?
So, sir, in this thing, we will first 2 things we'll have to look into it. One would be the size of the pneumothorax, and the second will be the stability of the patient. Now, for stability of the patient, respiratory rate has to be less than 24. Patient should be able to speak in 1 full sentence. BP should be in the normal range of 120 to 60, and patient should not be tachycardic. Now, in this, even though there was few signs of instability was there, but clinically the patient did not look unstable.
Okay.
She was able to talk in one full sentence. So at this point in time, we could just continue the patient with high flow oxygen and observe close monitoring.
Ideally, the treatment of pneumothorax, as you said, depends upon the clinical features. Most importantly, if there is any features of instability, hypotension, immediately need to do a needle decompression followed by an ICD placement. But there is no hypotension as such here. After oxygen started, the patient's saturation improved and her breathlessness have decreased, and we can get an X-ray and see the size of the pneumothorax. Usually this post-procedure pneumothorax is usually spontaneously resolved after maybe 24 to 48 hours once you supplement them with oxygen and you observe them, and you have a facility to place an ICD when and when there is required, and you are very confident that you can place an ICD immediately when it is required before the patient is deteriorating. So rather than the patient going for hypotension and picking up a pneumothorax and putting an ICD is not a good thing. But if the same patient is here where a monitoring can be, continuous monitoring can be done, and you have a facility to place your ICD at any point of time, then maybe you can wait. But as per the guideline, this patient needs an ICD immediately because she is tachypnic. She has size of the pneumothorax as per the X-rays on the higher side. So definitely she needs an ICD. But depending upon the underlying lung pathology, so here she has already developed an ILD, and on top of that, putting an ICD and developing a BPF complications. You might wait because we know that it is a post-procedure complication, but technically speaking, as per the guidelines, this patient should be put an ICD, or bare minimum we can try to aspirate the pneumothorax. You can try to aspirate the pneumothorax and put her on oxygen and observe the patient. So that should be the ideal action plan in this patient. Sir, you come.
So to determine the size from the chest wall, there are two school of thoughts. One is a European and the other one is a British or some school
American
of thoughts.
and
British school of thoughts are there. But to determine the size from the chest wall to the visceral pleura at the level of hilum, it should be more than 3 centimeters to more than 2 centimeters to consider as significant. From the apex to the ribs, it should be more than 2 centimeters. So this patient did fall into a massive,
both the criteria.
Large pneumothorax. But since it was post-procedure, we did keep all the materials, equipments ready for an ICD, but we closely monitored the patient. So if at all the patient would go unstable, then we would put the patient on ICD right away. So, and then serial chest X-rays were also taken in order to monitor if the patient's
increasing the size of the pneumothorax.
Size of the pneumothorax was also noted. Then, moving on to the sample history. So, patient was a known case of hypothyroidism, and then following which she's had like one episode of thyrotoxicosis also in the past.
Thyrotoxicosis and hypothyroidism.
She had like overdose of drugs, and then she stopped. Irregular medications were there, and then she developed one episode of thyrotoxicosis.
Okay.
Is there any thyroid swelling?
Yes, she does. She does have a single nodal thyroiditis.
Usually this thyroiditis and all, maybe the initial part that you said thyrotoxicosis, it might not be drug related. It might be a primary diseases. She would have developed a hypothyroidism and she would have been treated for hypothyroidism, and post this thing she developed a hypothyroidism. That can be the possibility. Hyper to hypo. That is a usual pattern. They will be hyper for some time and they would have taken some treatment, and later on they will become hypothyroid. So that will be the reason. So can you just say any drugs can cause both these things, your lung disease as well as this thyroid? Amiodarone. So that is only one agent that you can consider whether she has been any time taken amiodarone for any of this any disease for arrhythmia, because both the thyroid dysfunction is a possibility, also an ILD is also a possibility. So maybe in the past she has taken amiodarone, but anything suggesting nothing.
She was on cyclophosphamide and dexamethasone for her pemphigus vulgaris.
Okay.
So then only 2 years ago she stopped her cyclophosphamide cycle.
So altogether she has some autoimmune diseases there.
So 2 years back her cyclophosphamide and dexa steroid medications were stopped, and at that point in time when chest X-ray was taken, it showed ILD pattern, but since the lower lobes were spared, it was not very typical of it, which is why they did a bronchoscopy.
What suggested them to go ahead with a biopsy, whether there was disease was getting progressed or not getting controlled with the routine management of cyclophosphamide or MMF. She was worsening. So what is the reason exactly they went
The
for a
thing
biopsy?
is, sir, she had persistent symptoms. She
Okay.
had shortness of breath, dyspnea on exertion, which was progressively worsening, plus intermittent wheeze, and along with this palpitations, chest discomfort. So she was in conservative management, but there was no much improvement in her symptoms.
Okay.
Which is why they further evaluated this patient. Bronchoscopy was also normal.
What is the build of the patient?
Patient was lean build, sir. She was lean build.
Obesity. It may be additional thing which may be
Causing the shortness of breath.
Shortness of breath. And,
Okay, yeah.
and then last May she also had COVID.
Okay.
19.
So it can be in post-COVID fibrosis also. It's one of the possibility. So the most importantly, she should have a proper evaluation, including in HRCT chest. Definitely, they would have done an HRCT chest, and they would have not get a clear-cut answer why she is worsening. So they would have proceeded with an biopsy. So let's leave that part alone. So this patient is having a pneumothorax in front of you. So suppose this patient suddenly deteriorated in the sense that hypoxia worsened. So you decided to put an ICD. So what are the things that you require to go ahead with an ICD placement?
So for ICD placement, it's an emergency bedside procedure. So we'll have to proper positioning of the patient.
First, you have to take a consent. But
okay.
any procedure, you have to explain the procedure, get a consent. Unless and until it's a life-threatening emergency, like a tension pneumothorax, where you need to relieve the tension, and then you put an ICD. So take the consent, explain the procedure to the patient, position the patient. So what will be the position of the patient?
Position will be in the recumbent position with arms being raised. For a
See,
proper
already this
exposure to
patient is
triangle of
breathless,
safety.
so making her lie down flat will be difficult thing. So maybe you need to keep her in 30 to 45 degree position, and hand should be the affected side, whichever side you are putting the ICD should be
raised
rested behind the hand.
head.
Okay.
So for adequate exposure, then we'll have to locate the triangle of safety. Now for triangle of safety, the borders will be anteriorly it will be the posterior border of pectoralis major. Posteriorly it will be posterior border of latissimus dorsi. Then the apex will be the apex base of the axilla, and then base of the triangle will be the inferior border of the fifth rib. So this
Inferior border of the or superior border of the fifth rib?
superior border of the fifth rib. So this will be the triangle of safety. So at this point in time, we will, after apply under sterile conditions, after applying local anesthesia, we insert, depending upon the size of the pneumothorax, it can range from 14 French to 24 French of chest tube can be used.
The thing is that you need only a smaller size of tube. You need to just relieve the air. You need not relieve the blood also. We are not suspecting a hemo. So we just need to relieve the air. So need to have a smaller size is more than enough. So 22 will be more than enough. And the most important thing is that there are different school of thought. There is one trocar method that we commonly practice in our ED, and there is also, but surgeons prefer to go ahead with the dissecting the pleura and inserting the different technique. So whichever technique that you are using, it's fine. But the most important thing, the location that where you need to put the ICD is the most important thing. So where will you place the ICD? You have the vascular structures.
So it will be on the upper border of the lower rib. Because
Upper border of the lower rib.
vasculature will be going on the lower border of the upper rib, which is why we'll be going down to the
So either you can place in the fourth intercostal space or in the fifth intercostal space. These are the safest area in the mid-axillary line. These are the area where you can go ahead and place the ICD. So explain the procedure to the patient, position the patient, get a local anesthetic and infiltrate to the skin and into the pleura and to the
making small nick and then
small incision,
then dissection,
and then you can do a dissection or you can use a trocar method. So when you using the trocar method, the only thing is that suddenly there will be a giveaway and you will be just going and inserting the trocar much deeper to the lung parenchyma. So that is one possibility. So if you are not experienced enough to use a trocar method, so don't use a trocar method. Dissect the pleura and make an incision to the pleura, then you insert the catheter. But you are confident enough to go ahead with a trocar method. The one thing that you can use is that maybe around 5 centimeter you can make a guard with your hand itself. So you can grip the trocar like this and this will be your guard. So the trocar will not go more than this area. So you should not holding the trocar like this. You should be holding the trocar like maybe 5 or 6 centimeter only. So that time only this much area you will be inserting. You will not be blindly inserting more than this 5 or 6 centimeters. So you use your hand as your guard, and that is the location where you can insert the trocar. Once you get the giveaway, remove the stillet, sort of a trocar stillet, and keep the catheter or the tube inside, and slowly you withdraw, and make sure that all the
All the
holes
holes goes inside.
or inside the inside the incision. So otherwise what will happen is that one hole is outside, there is no point, further air will get stuck in, the pneumothorax will not be reduced. And also make sure that the last hole is inside only, it should not be in the subcutaneous plane also. If it is in the subcutaneous plane, it will cause subcutaneous emphysema. So that is the next thing. And once it is secured, then you look for the column movement, and then you fix it, get a chest x-ray, and make sure that you are not lifting the water seal above the level of the chest. So again, clamping should not be done. Whenever you're shifting, one common mistake that people does is they just clamp the pneumothorax. That should not be done. Clamping should be avoided. So that is a bare things that you need to do when you're placing an ICD. Anything, sir?
See, for the safety of the patient and safeguard your skin, but always do under the ultrasound guidance. So a lot of cases reported in medical legal, and heavily compensation has been paid to the patient.
So possible complication like bronchopleural fistula, you are accidentally going and hitting the lungs. So BPF, it is a long lasting story. So the patient will not heal. So you will not be able to remove the ICD. So these are the possible complications. Then local hemorrhage, all those things, so failure of the procedure are there. But BPF is a long term complication that will have a tremendous problem for the long term difficulty for the patient also. So ultrasound guidance definitely yes. We have an ultrasound machine you can use wherever you want. So you get the help of an ultrasound guided. But the most important thing is that the procedure, you should be very confident in the procedure, and the trocar method, that's what we use. Make sure that you are using it as a guard, and it should be a controlled manner. Okay.
And
For that, rule out any splenomegaly and hepatomegaly also. If you are doing left side, take care. No visceral damages to anything, including the spleen. On the right side,
Liver.
take care of the liver. Okay.
And bronchopleural fistula can be identified with excessive bubbling of the water column. But if at all there is no water column, then you'll have to think of either displacement or blockage of the pneumothorax, which is...
That is immediately. Maybe after like 2 days, maybe the pneumothorax would have resolved. So you can think of removing the tube also. So since it's a very, this thing, you can remove the thing also. Okay.
So,
Actually, the movement of the water column up and down in this tube is the correct indicator whether it is functioning or not. Air bubble is coming, is still air is there or not. So sometimes the displacement of the catheter may cause the air bubbles may not be coming out also. Till the air collection. That will be judged by taking an X-ray or clinical deterioration of the patient.
How is the patient now? She's okay.
the patient is fine, sir.
Okay.
And then the other thing, so if at all it is a tension pneumothorax, there's been a change in the site. Before we used to do it in the second intercostal
Now in the
space.
fifth intercostal
Now it is
space,
in
the same space
same
where we-
space of the ICD.
Okay. Okay. Fine.
That's about it.
Thank you.
Thank you.